Okay guys, Dr. Chad Peters here from drchadpeters.com, Rehabtogo, and Chad Knows. Today we are going to dig into the knee. Oh man, I apologize for anybody that has had knee conditions before. That just sounded terrible. How about this? We're going to learn a little bit about the knee today, so perhaps you can make some better decisions on your own care. If you're joining me as a practitioner, like an athletic trainer or a sports-based chiropractor, physios, PTs, lots of different jobs that I hope this sort of website attracts. Let's learn a little bit. Let's dig into it. Perhaps you are a client and you have knee pain at home. Let's learn about this thing so we can all make better decisions. Well, first of all, with the knee, there are a lot of different conditions that have a very similar pain scale. They kind of feel the same. So you're going to hear about stuff like Osgood-Schlatter's disease, jumper's knee, chondro, tight quads, patellar tendonitis. No, it's tendinosis. It's anterior chain dominance. Here's the thing, guys. There's a lot of big-time names for these things, and they all do have a little bit different meaning. So if I'm in the field and I say to another practitioner, hey, we're going to work on this Osgood-Schlatter's thing, it helps direct our treatment and our idea. It's shortcuts. But I think too much time is spent sometimes on getting the diagnosis fantastic, and then the treatment just dictates based on like, okay, this thing, chondromalacia, has an entirely different treatment than what a jumper's knee does. And I think sometimes that might be a problem. So I want to go over this so we can kind of understand the conditions better. And I understand that different conditions need different treatments, because without that, we're getting different things. The understanding of this directs treatment. And I think as we get deeper into the understanding of these things, sometimes it will help our treatment options so we're not so pigeonholed into what to do. So my plan with today's lecture is to dive into this like the Beastie Boys circa 1987. We're going to drop the science. Let's learn a little bit about this. The anatomy with the knee. Basically on your anatomy with the knee, what you're looking at here is there's these monster muscles on the front side of your leg. These are the quads. Go ahead and straighten out your leg and really flex those things. You can feel them. I don't care if you have skinny quads or if you have quads like a bodybuilder. They are huge, strong muscles. They create a gigantic lever and you can crank on these muscles. They're also extremely able to grow quickly. They get fatter and bigger and more dense, like tightened up steel cables. Attached to the quads, all the muscles in your body turn into tendons. So attached to the quads, you can see these huge tendons. And then they all come to an anchor point at the tibial tubercle. And that's basically anatomy of the 1990s through, the thousands of years before that. Now, the new way of looking at this, and I couldn't really find a cool picture with this that wasn't like from a cadaver, and I didn't want to include it on this, but the fascia is really the overlying condition. So imagine this giant saran wrap thing wrapped around the entire knee. You've got that, and it's very spiderwebbish. You can see on the orientation of these muscles and tendons how it all kind of runs linear, right? Everything kind of goes up and down, all the little lines. Well, fascia is not like that. It's like a spider web, and that changes the way things work too. Now, how the anatomy turns into the physiology is that can tell us where the issue is, where the injury is, right? So you can see the bright red wording that says patellar tendon, and that would be like a patellar tendonitis. Basically, if you take your kneecap there in the middle, the tendons below the kneecap is called the patellar tendon. The tendon above the kneecap is called the quad tendon. But what I'm telling you guys is it functions as one gigantic unit, right? So those great big muscles are yanking on the tendons are yanking on the attachment points. If you're not getting something at that tibial tubercle where it all comes together, it may be at the tendon. It may be where the muscle and tendon come together. Or it may be on your kneecap. If it's compressing stuff so tight and you're not having an anchor point attachment, maybe it's just making your kneecap compress onto the femur behind it. And now that's a chondromalacia, the grinding. And I think because once you figure out the physiology, the quads are going to react very fast. If you're going to treat this thing, if you're going to come into my clinic, I'm going to treat you, I want to hack the system, right? Bones take years to change. They still change. They're always changing. It's not like we're fossils. Bone attachments, bone density, all that stuff changes. But it takes a long time. So for the most part, doctors just don't deal with bone changing. Tendon and ligament stuff we deal with all the time, but that takes months, right? You blow out a knee and you have to get surgery on it. That takes months and months to reconnect that structure to make it strong. Well, muscles basically take like minutes to days. So if you're gonna hack the system, let's get up to the muscles. Those are the springy, taffy built, able to work it. So let's fix the muscles is what we all say. So we get to the standard treatment. Let's just stretch it, or let's just foam roll the quads, or sometimes they're just foam rolling everything. They're foam rolling the quads, the IT band, the hamstring, the butt. They're just foam rolling for no other reason that we foam roll. Or you get these co-straps. And what's happening with the straps, like this guy is tightening up on his knee, is now that those monster quads aren't attaching to the tibia anymore, right? The lower part of the leg, they're attaching and pulling from that strap. So if you've got a super irritated attachment point, well, now you've kind of bypassed the attachment point. And so that's where these things got really popular. I just don't think they're the solution. So on the next slide, all right, we're gonna get into sports stuff here because this is built for sports people. There's a lot of things wrong with this slide. But on this slide, this is where you see how these things would be out there. And all of us have seen these. Now in sports like running and tennis, which were included on this little drop-down list, I get it. You're not falling on the ground very often, or you shouldn't be falling on the ground. But on soccer, basketball, and volleyball, when I see athletes with a co-strap on, I really got to shake my head. If you have a super sore knee, and these things sometimes can be so tender and so red like a cherry that you can't even wear jeans to school because the rubbing of jeans on that thing will make you cry. And now you're gonna wear one of these straps and fall on your knee in a soccer game? You gotta be kidding me. So that's one of my big problems. I hate them for sports. They do take the pain away initially, but they're not fixing the problem. And sometimes they don't even take the pain away. Where this girl has it attached is a horrible position. It's down there right on top of it. Why not just irritate the thing more? The other thing is she's not wearing soccer shoes and she's playing soccer. You can tell this is something that was done at Madison Avenue with models and it wasn't actually done. I got a lot of problems with them. So let's get into the new evolution, right? If our first evolution was, oh, it's tight quads and all we're doing is stretching, I gotta throw my man out here. I gotta throw Lee. Not so fast, my friend, because the hamstring is equally important. The front side of your body is the quads. The back side of your body is the hamstrings. And there's a ratio that has to be done. So when you find out that you cannot get these quads to loosen up, despite the stretching, despite the foam rolling, despite seeing your athletic trainer 100 times, it isn't loosening up. Well, it's probably because you have a weakness on your hamstring. The ratio for the legs, basically we can argue this depending on your sport, but it's basically 60% of the strength of the body in the leg should be from the quad and like a 40% from the hamstring. And those ratios just get off. So much of what we do builds up that quad that most of my patients are probably running around on like an 80-20 ratio. So that now prompts the new revolution or evolution in the healthcare. Well, let's just make the hamstring stronger, right? So you're gonna get in here and you're gonna make the hamstring stronger. And what really is cool and terrible at the same time with our industry is we can make hamstring exercises as difficult as you can imagine. That way you have to come back to our clinic because if you try this stuff at home, you're gonna hurt yourself. And that is ridiculous. And hopefully nobody watching my site is this type of therapist or practitioner. I don't want that happening. It goes back to the ratio and it goes back to balance. We want this thing to be working the right way. Now I have one other problem with most of our hamstring strengthening because I do think it's part of the component. But did you see on both of those slides where I showed you the hamstring, the only thing that's bending when you make a hamstring stronger is your knee. And I challenge you to find anything in human movement where just the knee is bending. Every time your knee bends, the hip bends. So if you're gonna work on a hamstring, you have to work on a hamstring in a way that you're tightening it up while you are bending both. So on this little video I have here, you can see how we have to cue this. Now, most people cannot even make their hamstring contract when their hip bends. So on the video, you can see I'm grabbing the front side of my muscles. I'm grabbing the hip flexors, which basically come down into the quads, and you feel those flex. Now, I'm gonna have you try to grab your hamstring and see if you can make that flex. It's really easy to flex your hamstring when you're only bending the knee. You should be able to get that same feeling when you're bending the hip and the knee. and a lot of times you can't get it. And if you just can't get it, well, it's a motor control issue usually. So pause this video, go back over to my motor control and check that one out, because that's probably what you've got going. And then let's not forget what else could be going on. Joint mobility. It's important, man. And I know I'm saying it as a chiropractor, but I don't care what your field is. If you aren't getting those joints going, you're missing something, because there's probably something happening upstream. The hips aren't working right, or your pelvis isn't moving the right way. Perhaps it's downstream. Your feet are terrible. You wear shoes all day long and your feet are jacked. So my thing is, it's not one thing. If you're gonna go in there and try to fix this, you have to fix everything. You can't just do one thing and expect good results. The pain may go away, or let's say you just did ice and a co-strap and the inflammation goes away. You still haven't fixed anything. As soon as you go out and start working out, it's gonna come right back again. So here's my Rehabtogo protocol. Basically, this is what happens when you come into my clinic, and the way I would like you guys all to start looking at this stuff. If there's inflammation, we have to treat the inflammation. Because if something is inflamed, your body is on threat. And I think the next video that I'm gonna put out there is new terminology that needs to be used in the sports world. On threat is a fantastic terminology for this. If you're inflamed and you've got an issue at your tendons or your chondromalacia area on the backside or your quad tendons or the muscles, no matter what, you've got inflammation, your body's response is let's protect the area by locking down everything. So you have to treat the inflammation first as stage one. You can work the tendons without irritating them. You can use the tools, you can use cups, you can use whatever I'm not telling you guys how to be practitioners. You guys use what you like. I don't think you should just dig in there like we did 10 years ago with these instrument-assisted soft tissue mobilization and just bruise the crap out of people and think, oh, we're really getting away. I think what you're doing is creating more threat, and it's just going to lock down tighter. Then you got to move on to your next stages. You have to down-regulate the quads. Nobody out there should still be saying we need to make your quads weaker. Do not take athletes with healthy, strong muscle and make them weaker. And you know the lateral releases and the different quad releases are at a much lower rate in regular people than they are like in the top level athletes. So we don't want to start cutting healthy muscle away anymore. We want to keep that stuff going, but we can down regulate. That's another term we need to use. Down regulation, kind of shutting it down a little bit so it's not pulling so hard, and then up regulate the hamstrings. Let's get the balance back. If you're having trouble with this stuff, it's probably a motor control issue. So go check that. And then use your appropriate treatments. The tape works really well. I like the tape here. I think it gives you a great response back to your brain, so your brain's not paying attention to the area. You've got lasers. You've got the electric stim. You do you. You know what you do as a practitioner. You do that part. And then let's get to the next step, which arguably is the most important step. It's just not the first step. Once you have these athletes or yourself back on track, now you got to figure out why. Where is this coming from? And most likely it's a technique problem or a form problem or an overtraining problem or an overload problem. That's where your coaches and your athletic trainers have to be involved with this stuff. The days of just listening to your pediatrician say just rest it for 6 months and it's going to get better, that has to be done. That is over. Let's get into what is causing this thing. Too many times I think we do this stuff out of order and it just doesn't get there. If you guys are struggling with how much stuff to do, come on guys, we can do it. Most of the time doing these things in the right order and the right steps, it's only taking a few extra minutes. If you can't spend 10 minutes on your own body or your athlete's body, get in a different profession. Outcomes, when you do it right, this simple. In 3 to 4 applications, 3 to 4 treatments, 3 to 4 clinic visits, whatever it is, you should have major results. Huge results where the patient or that client or the athlete says, man, I'm feeling way, way better. I see this is doing better. The inflammation's gone, whatever. If you haven't got monster results in 3 to 4 visits, you're doing something wrong or you're doing something out of order or it's a different problem than what you thought. Either way, be the detective. Get a better direction so you can start working these things. Guys, that's how you handle knees in the modern era. I hope this gets you the information you need. Anything else? Let's move to it. I want to get more information out there, so let me know what you need. You just finished another Rehabtogo. I know you learned something. If you want to know when the next one's coming out so you can be ready for it, all you got to do is subscribe. Hit the little bell, it'll ding and tell you, hey, Chad's got another one coming out.
Don't forget to tell your friends, especially those that are like-minded, the kids, the students that are getting into this industry. They know what direction they want to go, but no idea how to get there. This information helps them make those decisions. Look forward to seeing you guys next time.